Thank you very much for the welcome, and thank you very much to the organizers for having me. And hopefully we'll try to get you a little bit more on track here today, but we'll do the best we can. So it's a pleasure to be here to talk about immuno-oncology as an overview, and then also specifically talk about toxicity management. I do have some disclosures. I am on some speaker bureau, and I'd like to point out our new cancer center, which is not so new anymore. We've actually been open for a little bit more than 5 years. So I'm just going to go with a quick overview on the adaptive immune system, because some of you are not in medical oncology, so it may not be as common to all of you. So when we look at how immunotherapy works and why it's effective for our patients, we begin to look at the tumor and the tumor microenvironment. And as the tumor begins to go through apoptosis, there is a release of antigens into circulation. Those antigens are picked up by other antigen-presenting cells, also known as dendritic cells. Those dendritic cells will bring the antigens into the secondary lymphatic system and begin to activate T cells, which are in the resting phase. Once those T cells are activated, they begin to mature and proliferate, and they're now been educated. They're active T cells. They go into the active, in surveillance, and go into the tumor's microenvironment, recognize the tumor as foreign, and cause tumor destruction and further apoptosis. And so this is an ongoing perpetual cycle, because as the tumor begins to go through further apoptosis, more antigens are released. And so this cycle should continue to occur. And that's how your adaptive immune system should occur in the ideal setting. However, we know that there are several checkpoints that actually shut down the immune system so that it's not effective, and several of which have been identified. And this is a very busy slide showing you some of those checkpoints that either accelerate the immune system, so that cause it to be further active, and those that are considered to be inhibitory signals. And so they're kind of color-coded for you. The red signals are inhibitory signals, so they help to suppress the immune response, and others, again, in the blue or kind of purple color, are the ones that increase the immune response. Now, we need to have these checkpoints so that your immune system does not become overactive, and we don't have a process of autoimmunity and destruction of normal healthy tissue. So this is a check and balance system. So we now have identified, and we'll talk about a few key checkpoints that have been targeted now when we look at the development of new immune therapies. And those are the PD-L1 ligand interaction, and also CTLA-4. Some work in the central immune response, and others work more peripherally. And those are the ones, CTLA-4 and PD-L1, PD-1 ligand, that we know the most about. So we do have a ligand that is also on the APC, the antigen-presenting cell, or the dendritic cell. You've got your activated T cell, and then also the tumor. So between the interaction, we've got new drugs that have been developed, not only for just thoracic oncology, but other solid tumors and now hematologic malignancies as well. So those that work at the PD-L1 and PD-1 axis are these agents. Nivolumab's been approved, pembrolizumab has been approved, atezolizumab has been approved, and durvalumab have been approved currently. And when we look at the CTLA-4 axis, we've got ipilimumab and tremelimumab that have been approved for other diseases. So these are checkpoint inhibitors. So we're not talking about all immune therapies. There are others that are active in other parts of the immune system, but when we specifically look at checkpoint inhibitors, the ones on the left, these are all the ones that have been approved thus far. And when we look at where they really target and where they block, you can see that there are either those that block the anti-PD-1, or the ligand, which is its associate, the PD-L1, or CTLA-4. In many of the doses, the drugs now, there are fixed dosing, but it's not necessarily true for all of them. These are all of the different diseases that we have approvals for now in these checkpoint inhibitors, and this slide has one more addition under nivolumab, and that's for hepatocellular carcinoma, which was just approved actually a week ago. So it's a really rapidly progressing field, and it seems like every week you turn around and there's another indication for one of these checkpoint inhibitors. So the fortunate thing is that the mechanism of action is still exactly the same, so it doesn't really matter what disease that you're talking about. And so the side effect profile and the management is very, very similar. And so that's the one thing that's fortunate about the checkpoint inhibitor types of therapies, and which makes it a little different than the cytotoxic or targeted therapies that we look at. So let's break it down just a little further. When we look at the approval specifically for non-small cell lung cancer or lung cancer in general, we now have nivolumab, which was the first one that was approved. And this is approved in the second-line setting, so after failure of a platinum-based regimen. Pembrolizumab is now approved in either the first-line setting, so for patients that have a tumor proportion score, so that TPS score is the amount of PD-L1 that is found on a tumor. So if you've got a score of greater than 50% as a single agent, it's approved, but it's also approved in combination for those that have greater than 1% tumor proportion score, and then also approved in the second-line setting. Atezolizumab is approved for non-small cell lung cancer as well, and that's in the second-line setting after failure of a platinum-based regimen. And some other agents that we have are coming up that any day now, I would expect in the next several months, we'll see durvalumab and avelumab approved for non-small cell lung cancer. There are currently trials that are looking at combination regimens, so combining checkpoint inhibitors to see if we can avoid mechanisms of resistance, and that's using an anti-PD-1 or PD-L1 agent in combination with a CTLA-4 agent. When we look at those in combination, the dosing is a bit adjusted because the toxicity profile is increased when you're looking at dual mechanisms of blockade. So the dosing may not be exactly the same, so you need to just really check what your the current indication that it's approved. So these are our approvals thus far. So with those new approvals, we have to be considerate of the fact that there are toxicities that are associated with those, and what we call those are immune-related adverse events, or you might see IMAE in some of the literature, so immune-mediated adverse events. These are different than the toxicities that we do see with cytotoxic or targeted therapies, and it really is based on the premise that immune checkpoint inhibitors promote T-cell activity, but they're not limited just to the tumor cells, so it's not confined just to anti-tumor effects. So amplification of that immune system can lead to unrestrained T-cell activity on normal healthy tissue, and that's really the underlying mechanism for how these toxicities occur. So the most important thing that we need to consider when we're managing patients on these immune checkpoint inhibitors is that we need to rule out other causes of a toxicity first before you make the assumption that it's immune-mediated. So in most cases, it's really a diagnosis of exclusion. So you can have an inflammation of any body area. So this is not meant for you to read every single thing on it, but just to give you a sense that any body system or any organ can be affected, but with inflammation, T cells can attack any normal healthy tissue, anything from the lungs to the endocrine system, cardiac, gastrointestinal system, hematologic toxicities, ocular, skin, liver, kidney, musculoskeletal system, and neurologic. So it really does not spare any. But the important thing to keep in mind is that even within those organ systems, there's a wide range of inflammatory autoimmune responses that can occur. This is a little difficult to see, but I know that you're going to get copies of some of these slides, but this was a retrospective analysis that my colleague Emily A. Duffield and I did, and we looked at all of the studies that have been done that really led to the approval of all these checkpoint inhibitors to see if there was any difference in the toxicity profile of each of the agents, whether they were given as single agents or whether they were given in combination. And so the little grid on the bottom is kind of color-coded and lets you know whether it's an anti-CTLA-4 agent, anti-PD-1, or anti-PD-L1 agent. And when you look at the bottom axis, this really is, the bottom axis is the number of months. So you can see that the onset of a toxicity can be very variable from at the early onset of treatment all the way out to, this goes out to 12 months, but we can see toxicities that occur even 24 months after the initiation of therapy. And there's a little bit of variability in terms of when these toxicities occur, but not significantly by agent. So if we look at the top one, for dermatologic toxicities, they occur a little bit earlier on compared to some of the other toxicities. The next one that most commonly occurs are gastrointestinal toxicities, then the endocrinopathies, and then there's a little bit of variability in terms of the remaining organ systems. So we can leave that for you to review either in the article, if you take a look at that, or also on the slides when you get that. But just to see that there is kind of clustering between the different drug categories as far as the occurrence of those toxicities. So how do we manage patients that are on immunotherapies? And for all of us in this room have a variety of different rules for how we're going to manage patients. But really taking a look at Champlett's little algorithm for the 5 pillars of toxicity management, the key thing really is that you want to prevent the occurrence of a toxicity if at all possible. And that really involves in really knowing the potential immune toxicity profile that perhaps can occur for patients, identifying any risk factors that patients might have that might lead them to an increase in toxicity, and then particularly informing patients of the potential onset of these toxicities so that they make sure that they alert you to those, the occurrences. You want to be able to anticipate the potential toxicity. So that's doing good baseline assessment of your patients. You need to have a good understanding of what their baseline organ function is and look for really subtle variances in that organ dysfunction so that you have an early identification of a toxicity. And then continue to monitor patients even when they're off treatment, because some of these toxicities, any of them, can actually occur even months after treatment is discontinued. So it's important to educate your patients that even when they go on to another, let's say a cytotoxic agent or a targeted therapy, or even if they're off therapy, if they find themselves with some type of an ailment or an inflammatory process, they need to consider the fact that it could be due to their immune therapy. And then it's detecting. So early detection and monitoring of patients is important, and really comparing to their baseline symptoms. And then treating them symptomatically, and that may involve immunosuppression to help shut down that autoimmune response. And then monitoring the patients, either on therapy or if they have to come off of therapy, monitoring their immunosuppressant therapy. So this algorithm is just a really general algorithm, and I'm not going to go into it in detail because you're really fortunate that you've got these new guidelines that are in your possession right now that you can refer to as far as the specifics for how to manage the toxicities by grade in terms of the initiation of steroids. But in general, grade 1 toxicities, you can usually safely monitor the patient without the initiation of steroids, and in most cases continue the immune checkpoint inhibitor. In general, grade 2 toxicities are mild to moderate, and depending on the organ system, steroids may be introduced. Grade 3 and 4, in most cases, in almost all cases, the immune checkpoint inhibitor is going to be discontinued, and immunosuppressant therapy with steroids are going to be initiated. And then there are certain refractory guidelines. So if patients are not responding to steroids, it may be necessary to introduce an additional immunosuppressant agent, and so we'll go through some of those. In general, if patients need to start on steroids, and this is where all of you come into play, is that patients, the key thing is when a steroid is started, it's not a Solumedrol dose pack. So it's not what you give to somebody who has an inflammation from poison ivy, and you're not going to just treat them for 3 days. In general, when you start steroids at the therapeutic dose, you need to once they begin to stabilize and their toxicity is reduced to a grade 1, you begin to taper that steroid over at least 30 days. It may be necessary to go to an even longer steroid taper for patients that are not responding down to a grade 1. A rapid taper may result in a flare or a recurrence of the toxicity. It's important when patients are on long-term doses of steroids that they're going to be at risk for gastritis, so they should be on a proton pump inhibitor. They may be at risk for a flare of diabetes, particularly if they already have a diagnosis of diabetes, so make sure you monitor their glucose levels. If you're on long-term steroids, you're at risk for opportunistic infections, so introducing antimicrobial and antifungal prophylaxis is recommended. For patients that have to be on even longer steroid dosing, such as months and months of therapy, they will be at risk for osteoporosis, so they should be on vitamin D and calcium supplementation. So for each of the grades, now again, you've got the toxicity guidelines in front of you, but I just want to point out a few different things. So the patients that have a skin toxicity, dermatologic toxicity, may present with rash, but some may present even just with pruritus. The key thing is that you want to rule out other causes, rule out cellulitis, rule out other drug reactions, whether it's sun exposure or radiation recall, because the management could be very different. In general, for dermatologic toxicities, we can manage with topical steroids, but if it is refractory to topical steroids, they may need either oral steroids or IV steroids. For gastrointestinal, most common toxicity in gastrointestinal is going to be either diarrhea, but you also, the risk for this is that you want to make sure that the patient is not developing a peritonitis, and they also could develop even perforation. So you want to assess them for peritoneal signs. You can actually have peritoneal signs without having diarrhea, so that's one of the key things I want you to understand. So if a patient even says they've got a lot of cramping and a lot of increased distress, and even if they have just one loose stool a day, you want to make sure that you're considering that they could be developing an early colitis. So you want to be monitoring them for that. The key thing with GI is to rule out other toxicities such as bowel infection, particularly C. difficile if the patient's recently been in the hospital. So you want to get a stool culture to make sure that they don't have an infectious process and treat that appropriately. Pulmonary toxicities. Patients with lung cancer are actually at higher risk for developing pneumonitis due to an immune checkpoint inhibitor than patients with some of the other solid malignancies. In fact, patients with pneumonitis, patients with lung cancer develop a pneumonitis picture at a higher rate than those, let's say, melanoma. Melanoma patients actually demonstrate more of the skin toxicity and the GI toxicities than the lung cancer for some reason. For pulmonary, you have to rule out other causes. Is this progression of disease? Is it lymphangitic disease? Is it pneumonia? Do they have a pulmonary embolus or a pleural effusion? Probably the easiest screening for these patients is to make sure you understand what their oxygen saturation is, both at rest and with ambulation. You don't necessarily have to do a 6-minute walk test, but even to get them to walk from here to the end of the room, know what that is at baseline, and then understand when there's a change in that, and that oftentimes can be a really inexpensive way to see if they're having any distress. Hepatic toxicities tend to be just laboratory toxicity, so you want to monitor laboratory functions as well as renal. So monitor their LFTs as well as their serum creatinine and BUN. Cardiac toxicity is very rare, less than 5% of patients, but if patients do complain of chest pain and heaviness, you want to make sure you get an echocardiogram and an EKG to rule out pericarditis or myocarditis. Neurologic toxicity is also very rare, but patients have developed peripheral neuropathy, Guillain-Barré, myasthenia gravis type of syndromes, and so you want to make sure that you do a full neurologic consult. The first thing you want to do is rule out that they've got leptomeningeal disease or they've got brain metastases first, and then appropriate consultation with your collaborators in neurology. Ocular toxicities can be anything from conjunctivitis, uveitis, iritis, and so you want to refer to an appropriate ophthalmologist that really understands immune checkpoint therapy, and the patients typically will need topical corticosteroid eye drops. Hyperthyroidism, hypothyroidism, and the other endocrinopathies are very common, particularly with the checkpoint inhibitors. Typically, the thyroid is the more common organ that's affected. We usually see hyperthyroidism first. You've got an inflammation with thyroiditis. The thyroid then burns out, and then they become hypothyroid. Typically, we don't have to treat hyperthyroidism. Patients, again, usually convert to hypothyroidism, and you want to be monitoring their thyroid function tests. Patients need to be instructed that if their thyroid burns out, they will be on lifetime thyroid repletion. So even if you discontinue the immune checkpoint inhibitor, they need to know that they're going to continue on their levothyroxine. So sometimes patients think, okay, I'm off checkpoint therapy, I can stop that, and they can't. Their thyroid is no longer functioning. Hypophysitis can occur. Patients might complain of a headache, dizziness, blurred vision because they've got an inflammation of that pituitary gland. So the first thing we think is, do they have brain metastases? So we want to make sure we get an MRI of the brain with pituitary cuts to make sure that we're looking for that inflammation. And in most cases with any of the endocrinopathies, just hormone replacement is enough, and patients can often go on to successful treatment. So the key for nursing, oncology nurses, is that you want to make sure you assess patients' baseline organ function, understand if they're at risk, do they have any underlying autoimmune diseases. I will tell you, patients on the earlier clinical trials that we did not treat that had underlying autoimmune diseases, but we're beginning to challenge these patients now, so you want to make sure that you know that they're at risk for flaring those diseases. Telephone triage is really key, and especially medication reconciliation, understanding if patients are on immunosuppressant therapy and on steroids. Telephone triage guidelines are really helpful, and I really loved those guidelines that our earlier colleague presented from the UK, and I think that might be our one of our next projects for developing those immune-specific telephone triage guidelines. And again, the role of the oncology nurse, letting patients know the different toxicity profile of immune checkpoint inhibitors, because in most cases with early identification and early intervention, these patients can go on to successful management and often re-challenge with the immune checkpoint inhibitor, and they can have therapeutic effect. So really setting expectations for patients is really key, especially letting them know the time to response for therapy is oftentimes a little different from that with typical therapies. Just a couple of seconds, there are other influences on checkpoint response. So there is some variability. Patients that have higher mutation burdens, such as lung cancer, actually respond better than immune checkpoint inhibitors. So those that have a higher mutational burden. There's actually a lot of work now really looking at patients' gut microbiome. So yes, we are doing lots of stool collections to look at the biome. And those that have higher levels of diversity in their gut microbiome actually respond differently. So there's a lot of work at looking at patients that have been on high-dose antibiotics, and if that's sterilizing the gut, those patients actually respond less favorably to the immune checkpoint inhibitor. So really being good stewards of antibiotic therapy is going to be very helpful for us as well, because you sterilize the gut and they don't respond as well. And also age may have an influence on response. So key take-home points, toxicities are present. The more grade 3, 4 toxicities tend to be less than 10% of the population, but early identification and management, patients again can go on to successful management with their immune checkpoint inhibitor and hopefully optimal benefit from therapy. So I will stop there and really encourage you to use and give us feedback on the guidelines as well. I think those will really be quite helpful for you. So thank you.